I'm a professor in the Department of Internal Medicine in the medical school. I'm also a professor in the Department of Health Management and Policy in the School of Public Health. My role is to direct the Center for Value-Based Insurance Design, which is truly a multidisciplinary, multi-stakeholder unit. I had a dual degree in economics and chemistry and took those multidisciplines to think not only about the delivery of clinical medicine, but healthcare systems. I trained at Harvard Medical School, went back to the University of Pennsylvania, where I also was a Robert Wood Johnson clinical scholar. It was during those years that I was able to extend my medical knowledge and prior background in health services research to really start looking at larger systemic issues. About 15 years ago, I started collaborating with some health economists, and we realized that people, even with good insurance in the United States, were not doing those services that we as clinicians were begging our patients to do. They were saying they couldn't afford these services even though they said they were insured. Thus, the creation of what is now called value-based insurance design, a brand new idea that sets consumer cost sharing, the amount of money that patients pay out of pocket, not on the cost of the service, but the value. This idea has caught on among multiple stakeholders. It's caught on across party lines, Democrats and Republicans, and we've had great success moving the value-based insurance idea forward from the ivory tower of academia to real implementation in the real world. The most important issue that we have been confronting in the healthcare system is what we call cost-related non-adherence. If you make people pay more for something, they'll buy less of it. And Americans are being asked to pay more and more for healthcare services, regardless of whether they're high value or low value. There has to be personal accountability and responsibility. But we'd rather have patient out-of-pocket spending be based on value instead of cost. The creation of the Institute of Healthcare Policy and Innovation was a huge step forward. I think in two ways. One is by creating the Institute in a virtual way, would be able to go much further than we've gone before, just to allow people to know that there might be a place or an idea for multidisciplinary researchers to come together. What makes Michigan different from other universities who are trying to make this happen virtually is the availability of physical space for individuals who have offices in obstetrics gynecology or pharmacology or social work to come and actually literally be together physically. And while email and Skyping are okay, the idea of having colleagues in a place that you know you could go and meet not only the people you're bringing together, but oftentimes people who are down the hall and around the corner who also have interest and can contribute to the conversation has been an amazingly positive bonus. Given the core multidisciplinary and multi-stakeholder function of IHPI, I think it's perfectly suited to engage in healthcare discussions. Oftentimes, policy doesn't wait for the best science, and sometimes decisions need to be made before the experiment is done. We will always be based on research because we are the University of Michigan, but I think what an additional element that IHPI brings to the discussion is what we can do in the meantime, how we could guide where funding sources go and where priorities in research might go, and also engage in the political discussions which often have as big a role as research in deciding where the future of healthcare delivery in this country might go.